So I hurt my back this summer again playing golf, and I finally went and had my own first lumbar MRI. And we joke around sometimes as surgeons, like, that's for other people, not for us. But I was in a bad way. And, so I got off the MRI table in my gown, because you have to take your clothes off. You can't have any metal, that sort of thing. And I scurried around to the control room and I said, let me take a look. Let me drive this thing and let me take a look and see what's going on.
I'm the doctor again.
And, although when you're in the gown, it's hard to have the same kind of gravitas.
Sure. Right? I'm sure you did wonderfully though.
And listen, my L4-5 is pretty shot. And what's the first thought that I have? First thought is like, oh gosh, I hope I never have to have surgery for that. But the second thought is, gee, I hope this is amenable to some motion preservation type technology.
Welcome back to another episode of the Spine Pod. I'm Courtney Schutze. I'm here with my co-host Brady Riesgraf, and we are in Manhattan, New York. And we went to OrthoManhattan, and who did we sit down with?
We got to sit down with Dr. Jonathan Stieber at OrthoManhattan, and this is actually our second trip to New York City.
How lucky are we?
Absolutely incredible, but just grateful that we get to sit down with surgeons like this and someone like himself that has so much experience. He's been in practice for almost 20 years now, and he was actually around in the early days of motion preservation, right? So in some of those early trials and early tribulations, and I think you learn a lot from those, both failures and successes on the side of industry. And he's been able to integrate that into his practice. And you can tell just by the way he tells stories and the way he talks. So I think that's really exciting to be able to sit down and tell that story.
I agree. He's an amazing storyteller. And I think perspective is really important. And he has that, right? Of getting to see the early days of motion, and that now that motion is coming back, and then you have integrated technologies. I think he is such a patient-centered surgeon, which we absolutely love to see. So he has so many great nuggets to share with our audience. And I just really enjoyed this conversation.
Me too. I think that's a great point. He is someone that's integrating all these enabling technologies, right? We talk a lot about motion preservation, but then we go on to talk about robotics and navigation and MIS and how all these technologies are coming together to provide a higher level of care. And to your point, he's working with all these different technologies to promote better patient outcomes. I think that's really exciting. You can feel it in the way he converses, and to be able to sit down with him, I think it was just really special.
I agree. So please enjoy this episode with Dr. Jonathan Stieber.
Dr. Jonathan Stieber, thank you so much for taking the time and sitting down with us today.
Happy to be here.
Well, we're fortunate enough to be in New York City here, sitting down in New York City in your beautiful office. We were able to make it all work. You've been running wild with clinic all morning, so this has worked well, and I'm glad you had the time to sit down.
Welcome. So we're at 52 in Madison here, in the heart of the Plaza district of New York City. The audience can't see it, but if you look outside the window here, we're a stone's throw from St. Patrick's Cathedral.
Beautiful. We saw it as we drove by.
On the way in.
Yeah. We were like turning our head outside of the window, like, oh my gosh.
And fun fact, we're at 45 Madison Avenue, which is the old CBS building. So,
really?
So my father told me that when he was a kid and he would listen to CBS radio, you would send your contest entries into 45 Madison to CBS. So it has some history to it as well.
How cool. That's really awesome.
Well, it's been a lot of fun exploring, so you here, I want people to know who we're sitting down with. So you're the director of the Spine Center here at OrthoManhattan, which is where we're sitting. And you recently opened up a practice as well, OrthoEnglewood. And so you've got that going on. You're also a professor at the Icahn School of Medicine at Mount Sinai, as well as NYU Grossman School of Medicine here at NYU.
Well, associate professor.
Associate professor. You've got professorships and you're exactly right.
You're busy.
Yeah,
that's the point.
That's exactly right.
You have a couple things that you're doing.
That's so true. And you've been featured by Castle Connolly. You've been featured by New York Magazine. I've seen you on the New York Journal speaking. And then you've got a YouTube video that I believe has 1.2 million views, if I'm correct. So we're over here trying to get views as well.
Actually, why we wanted to sit down with you today is if you could tell us how to get 100 million views on a video.
It's all about the content.
Yeah, exactly right. That's exactly right. But I just want people to know who we're sitting down with here today. And, we're fortunate to be able to sit down with you and have this conversation. You've had a lot of experience, especially in motion preservation, that we want to be able to talk about today. I want to bring it back, as we sit here and we're in OrthoManhattan, gorgeous office, middle of New York City. When you started practice or you started medicine, is this what you envisioned? Like, did you see this is what it's going to be like? Or what was it when you took your first steps into medicine?
Well, that's funny. This was never my dream to be a orthopedic surgeon in Manhattan. And one thing leads to another. And here I am. And here I've been now for 17 or 18 years. But I count myself very fortunate. I have fantastic partners here who are just all exceptional surgeons and, take care of a lot of notable people and celebrities and people that you would know. And we're able to be private here, but also academic at NYU, where we teach medical students and residents and fellows. And for a long time, I interviewed for the School of Medicine for NYU. So we really have the best of both worlds here. Plus we're in the middle of it all. So very fortunate.
Well, you talk about being notable too. I mean, we were just sitting out front and your partner, Dr. Cohen, was with Peter Attia on the Drive podcast.
And Alton fixed Peter's shoulder, and
wow.
and Peter sent me at least one of his sort of VIP patients. So again, we're lucky to have friends and to have colleagues.
So for context of who we're sitting down with, that's who we're sitting down with today. It's Dr. Stieber. That's what this partner, that's what this practice is like. It's amazing.
There's been some drive-bys in this waiting room today that have been interesting to see.
Absolutely right.
That's right.
So you talk about, being here and not knowing what was it that initially got you into medicine? What made you want to go down that path?
That's interesting. My late grandfather was a pharmacist. He always wanted to be a doctor. So I think that was part of it. I'm really one of the first doctors in my family, but I always liked working with my hands, building things as a kid. I mean, it sounds like a sort of a trite, medical school essay, but I like the Legos and the erector sets and
but
these
if it's
things.
True, it's true, right?
And then I was an athlete growing up. I played soccer and lacrosse, and I was actually a fairly accomplished fencer. I fenced at Duke for 4 years, and so a lot of the orthopedic surgeons have some sporting background as well. And marrying those things, trying to have a fulfilling career where I could teach, where I could help people, and then be able to work with my hands, build things, and accomplish something. I think that drove me to it.
Was it your time, in sports and at Duke that made you want to go into orthopedics? Because then you went to UPenn for medical school, correct?
Correct. I always knew that orthopedics was cool. And it was interesting surgery, and you have all the sort of nuts and bolts and toys. So there was some appeal for me, but that wasn't it alone. One of the things I liked a lot about orthopedic surgery in comparison to some other medical specialties was that there really is this non-operative piece as well as the operative piece that I see a lot of patients. I see a lot of friends and friends of friends that I see who are never going to have surgery, and I'm happy to see them. And then I have post-op patients who, I may follow for a period of time compared to some other surgical specialties or subspecialties where someone comes for a very, very specific problem, and you may fix that problem and never see them again, but it's more highly operative in some ways. So, that drew me to orthopedic surgery. among other things. I also like the idea that when you perform a orthopedic surgery that's successful, you're restoring function. Listen, my wife had thyroid cancer, and she had a thyroidectomy at NYU, by a wonderful surgeon there. And now she's as good as new, except she doesn't have her thyroid, and she has to take thyroid medication every day. Orthopedics, oftentimes you're bringing people back to where they were, before their injury or before their problem. And that always seemed to be, particularly satisfying for me.
I love that analogy and like that thought, because we haven't heard it like talked about that way before, but it's so true. And it's different, other types of surgeries, that's not the case, but you really get to say like, I want to get back to here, which a lot of times you get surgery, that's not what you're doing. It's just a fix, and you don't have the ability to potentially get back to where you were before.
No, I mean, it's super satisfying. So I don't fence anymore, but like, some other doctors, I've become an avid golfer. And so I had the chance to play a round of golf with one of my patients that I operated on over the off season, over the winter this year. And he has a regular caddy who walks with him and carries his bag and helps him, play. And the caddy kind of, kept going on and on, like, oh, he's hitting the ball so much farther. He's playing so much better. You did such a good shot. It's just it's a super satisfying thing to do with your time and your life. And I get to work with some really great people.
Did you have that on your Instagram too? I saw that like either at a discectomy or a microdisc or something along
I may have.
Well, it's just funny because we see those, and like the point that you make, we hear the story a lot of kind of like the deep, meaningful connections that you make, right? It's not a one and done surgery. They're not leaving. We're talking about that right before we started too, right? It's like, this is not the last time I'm going to see these patients, right? Like the hope is that you get them better and then you'll be seeing follow-up, but for good reason, right? But it's not the last time that you're seeing them when they walk out of your office. It's a whole different dynamic.
True. And listen, unfortunately, as people get older, sometimes they have other spine problems, sometimes remote. Sometimes I fix somebody's neck and they come back 10 years later and they have an issue with their back. And, so it's funny because it's like, I'm happy to see you. Like, I'm sorry you have to be here, but I'm happy to see you. I'd rather see my patients running into them in a restaurant in Manhattan someplace, but it's always nice to see people back and have that continuity.
Yeah. But it's a testament to you too, because I think if they weren't happy with the first procedure, they're probably not coming back 10 years later for a Lumbar.
Yeah, I would say it's the most sincere compliment or form of flattery to have a return patient for a different problem. You feel like you've built a relationship and some rapport and some trust, obviously.
Absolutely.
Yes. Yeah.
Well, so you touched on a really important point, and this restoration of function is something that we focus on a lot. I want to go back to, we were talking about this a little bit, when you finished up your training and kind of where the industry was at, right? Because you've been practicing about 20 years now, right? And so the industry has changed a lot, but when you were starting, motion preservation was kind of on the cusp, right? It was starting to come, and I want to hear a little bit about that. It was a
super exciting time, and I think it's one of the reasons I went into spine surgery because there was so much new technology coming out in sort of 2003 to mid late 2000s, and disc replacement was all the rage. There's a tremendous amount of academic interest. There's a tremendous amount of interest on the part of investors and sort of Wall Street, and just a tremendous amount of positive energy. And I was fortunate to work with some people in residency in New Jersey. I worked with Gordon Donald and Jason Cohen, who were part of initial FDA trial for a lumbar disc replacement, and they really took me under their wing. And I was, in those surgeries and going to meetings. In fact, I think we were very close to putting in the first Flexicore lumbar disc replacement, but if I have the story right, Rick Sasso heard that we were going to put one in and like opened up his OR early in the morning in Indiana so that he could be the first surgeon to put his in. So we were the second.
No lack of competitiveness.
As a true spine surgeon. Exactly right.
And then, and I was resident on that case. So that was just super cool for me. then I ended up coming up to New York and doing my fellowship at NYU and Hospital for Joint Diseases, as it was called then, with Tom Errico, who was an innovator in that space and had co-founded Spinecore, which made the Flexicore. Was ultimately acquired. The technology was acquired by Stryker Spine. But it was a super interesting time. When I was at NYU, they were finishing up the FDA study for ProDisc L, and then involved with the ProDisc C, IDE. And so I had a lot of early exposure to disc replacement, and there was a lot of promise and enthusiasm for it. And that panned out to a certain extent. You know, the lumbar data, at least the initial FDA lumbar data, you know, while I think very positive and maybe in some ways underrepresenting how effective lumbar disc replacement can be in the right patient, didn't show the same kind of superiority of lumbar disc replacement over fusion as I think a lot of people hoped.
Yeah.
Now in the cervical spine, it's a different story. The data there has, I think, tracked with our clinical experience, where it's really dominant. And you know, I do a lot of cervical disc replacement now, lumbar disc replacement in the right patients. And lumbar disc replacement can be a home run in the right in the right patient, the right indications. I think narrowly selected and performed correctly can be as good or better than any operation that we do in spine or orthopedics. Cervical, I look very hard to do disc replacement before fusion, but it's not the right operation for every patient and every problem.
Kind of starting your career at that time and seeing that all of that motion preservation kind of being around, how did that shape your philosophy of surgery over your career?
Well, listen, in orthopedics, we're here to restore function, right? You know, my partner right next door, Roy Davidovich, he's, you know, a superlative hip surgeon who's done a lot of notable people, including my mother, Denise. And
First and foremost,
I don't think I've seen him do a hip fusion. Right.
Yeah, of course.
You know, my partners, Adam Cohen and Alton Barron, they do a lot of, you know, shoulder replacement. I don't think I've seen them do a shoulder fusion. So, you know, the spine's a little bit of a different situation, a different part of the anatomy, because it's, you know, multi-segmental. Having a limited fusion does not inhibit us in the way that, you know, a big joint might otherwise. But you know, we're trying to maintain and restore function for our patients. So, you know, it's intellectually and emotionally satisfying and desirable to try to maintain motion.
And when you're going through that, so, because I get really intrigued, a lot of surgeons we talk to have been, you know, our late stage surgeons, right? So been practicing for 30, 35 years. And when they started and when they were training, motion preservation didn't exist for the most part, right? Or it did in small pockets, or they're trying to get things to market, but fusion was still gold standard. You were kind of an outlier if you were doing motion preservation. So for you coming up training and seeing that, was that the same case for you as when you were training, fusion was still gold standard? Or when you adopted the technology, was it already that was starting to become the gold standard, or you were looking at motion preservation as the gold standard?
I mean, I was really finishing my training, I think, in many ways, you know, at the emergence of this. Good and bad, right? So a number of the lumbar disc replacements that people were putting in or were trialing either never made it to market, right? So like Medtronic's Maverick never made it to market. Stryker's Flexicore never made it to market. The SB Charité was going in routinely, but then had problems and is no longer available. There's some others that are no longer available. The ProDisc L is the one that, you know, has had staying power and good data and good outcomes consistently, at least with that kind of longevity. But I was coming out at a time when disc replacement was really becoming widely available, and when minimally invasive surgery was, you know, a new thing. You know, when I was coming out, the only minimally invasive surgery as far as instrumentation was a Medtronic sextant. And then all the other companies started to come out with, you know, different minimally invasive screw systems. And So it was a very exciting time to be coming out and training. And I mean, truthfully, I really got very little training in minimally invasive surgery at NYU, even though it was a major center. And in many ways, I'm a self-taught, minimally invasive surgeon. And now I teach courses on minimally invasive surgery. So
absolutely. I want to talk about a lot of the, I think this umbrella of enabling technologies, right? Because I think we're kind of lifting patient outcomes across the board because we're getting access to better technologies, right?
Sure.
When I look back at motion preserving options, you talk about how it was, really, really hot when you first started. And then you had some, early failures, right? And a lot of that is due to, not knowing what patients to select, not knowing where to implant. Can you talk about where we are now, right? Because it was really hot. And then you had a little bit of, I don't know if you call it a downturn, but just a waiting period, right? To see who are the right patients? How well do they do over time? Where's the long-term data?
And innovation stopped a little bit for a while, right? You weren't seeing as many options coming out.
True.
True.
And now I think we're back in this up cycle, right? Where motion preservation is hitting. We're getting a lot of new options, right? We have, ProDisc, which is lumbar on the market and doing well. You have Premia, which has a TOPS, a facet replacement. And now you have, you were part of the trial as well, the Modus lumbar total joint replacement. Can you talk about kind of how that swung and where we're at now and kind of the field of motion preservation?
You bring up a few different things that are all interrelated, and there's some subtle differences too, right? So lumbar disc replacement done traditionally through anterior exposure or through the belly, which is not as bad as it sounds. Just so parenthetically, so my first exposure to surgery was when I was. So after my freshman year in college, I was a intern, not a medical intern, but like a summer intern at Newark Beth Israel Hospital with their vascular surgery group. And they had like a half dozen college students who were doing a little bit of research in animal lab and sort of shadowing. And it sounds crazy now, but again, this was like 1994. They would like let me scrub into surgery like I was a medical student.
It's amazing.
Right.
A different world.
Which I mean, is from a compliance standpoint, and
we've evolved.
Like from, they won't even let my daughter go up to round with me at NYU and like sit at the nursing station now. Like that's where we are now. But I remember scrubbing to surgery on an abdominal surgery, and I was just expecting when they opened the belly for it to be like this, like bloody stew of organs, right? And I couldn't believe that there was this like bloodless field, right? That you could see the organs and there were vessels, but as long as the vessels weren't leaking, that it was a controlled situation. And it was just fascinating for me. And then I think I proceeded to hold like a handheld retractor for about 3 or 4 hours until my arm felt like it was going to fall off. Yeah.
I'm amazed that you got to do that.
So I had some very cool experiences early on. But yeah, but back to anterior surgery, it's a lot more elegant than it seems. A lot of what we do, especially at where the spine meets the pelvis at L5S1, the fifth lumbar vertebra meets the first sacral vertebra. We do that through like a 10 centimeter bikini line or fan and steel incision, much like a woman would have like a small C-section scar. But it's actually smaller, right? Because we're not taking a new life out into the world. We're just, doing a fairly elegant surgery. But so anyway, anterior disc replacement, that's gone through its evolution with better devices, better materials, better understanding of patient selection. But that has its limitations. In the back of the spine, at every level in the spine, as there's a pair of joints, and those joints are real joints. Like your knuckles are joints, and they have cartilage, they have joint fluid, they have joint capsule, and there are times when there is isolated pathology of the intervertebral disc, the disc between the bones, and the joints are healthy or in good shape. And then an anterior disc replacement can be perfect. Mm-hmm. But for those patients who not only have a disc problem, but also have a joint problem, which is fairly common, that's a problem because you're replacing the disc and you still have the painful, sometimes unstable joints in the back of the spine. So the technology, the TOPS device, which actually that has been around since like 2004, has yet to find a home. I will say that one of my colleagues across town has been putting those in, and anecdotally talking to him, he's had some very good outcomes in the right patients. But you know, the Modus device from 3 Spine really is novel in some important ways. Now that device goes in through the back of the spine, potentially through minimally invasive approaches or incisions. And that device not only substitutes for a diseased disc, but can substitute for diseased or injured joints. And so that opens up a significantly expanded population of patients that we can help with motion preservation technology.
You're absolutely right. You know, and we get really excited just as all these technologies come together, right? Is you look at these and it's kind of been a piecemeal, right? So you have lumbar disc replacement and it's gotten better and better and better over time, right? And then you start to get facet replacement. And now, hopefully, like you said, just like a knee or a hip, we're going to go in and replace the joint, right? That is the ultimate hope, right? Yeah. Is that when you go in, you know, we don't see knee fusions, we don't see hip fusions. There's a reason for that, right? We're restoring motion. Granted, there are different biomechanical, you know, aspects to the spine that you don't see in the knee, that you don't see in the hip, but we're working towards that. But it's because of what we've built on over time, right? And the success that we've had with motion preservation and other devices over time.
Sure. I mean, listen, that's the goal.
Yep.
Like, so I hurt my back this summer again playing golf, and I finally went and had my own first lumbar MRI. And you know, we joke around sometimes as surgeons, like, you know, that's for other people, not for us. But I was in a bad way. And, you know, so I got off the MRI table in my gown, you know, because you have to take your clothes off, you can't have any metal, that sort of thing. And I scurried around to the control room and I said, you know, let me take a look. Let me drive this thing and let me take a look and see what's going on.
I'm the doctor again.
And although when you're in the gown, it's hard to have the same kind of gravitas, right?
Sure. I'm sure you did wonderfully though.
And listen, my L4-5 is pretty shot. And what's the first thought that I have? First thought is like, oh gosh, I hope I never have to have surgery for that. But the second thought is, gee, like I hope this is amenable to some motion preservation type technology, right? Because now, do I have patients who I've done minimally invasive fusions on, 1 or 2 level fusion, who are back to playing tennis, back to playing golf, back to skiing, back to yes, I do. And you can have an excellent outcome with those things. But emotionally, even for a surgeon, the idea of motion preservation is appealing.
It's interesting when you flip the table, right? Because you're operating all the time, right? And we've heard this from other surgeons as well. But then when you go under the knife, it's like, oh, wait a second. Like there are different things that I'm thinking about now, right? Being on the patient side of the table versus
I've had a few surgeries. I had one of my partners did a pec repair. I had a full rupture of my pec tendon some years ago. It's good as new now, but it's good as new and it's moving, right? It wasn't like a shoulder fusion. I may have 4 metal like MyTech anchors in my humerus, but I don't feel them.
Yeah. I think something else we talk about a lot, and I'd love your perspective just on your patients and what you see, is the idea that also patients just innately know they want motion. So a lot of times, you know, we're seeing patients drive that demand for like, I want motion preservation. You can even have patients, you know, we've had surgeons say they'll literally come with something printed out of like, I want this exact thing.
Oh, absolutely.
But I feel like, you know, really understand of like, I don't want to be fused because I understand that's not how my body was meant to be. And I'm curious if you've seen more and more patients kind of as technology has continued to be more accessible to people, see that be the case, or if you think, you know, just the perspective of patients when you're kind of given those options.
So, you know, especially where we're located in the type of practice that we have a lot of people come in from outside of New York, sometimes outside the United States, who have, you know, things that they're looking for very specifically, who are coming for second opinion, third opinion, fourth opinion. And we're fortunate to have a very educated, sophisticated patient population in our practice for the most part. And I do have patients I have patients that are coming in and talking about the pros and cons of different implants.
Yeah.
And, obviously I'm always happy to have that discussion with them at as high a level as, is appropriate or is required. Sometimes those patients aren't appropriate for disc replacement, and we take the time to explain, the pros and cons and risks and benefits and the why. But it is something I always look to do. Listen, first I look to not operate.
Right.
Right. I want happy patients. I want happy customers. Right. So first I look to not operate. I then look, what can I do that's the smallest thing that's going to be durable, that's going to get this patient the outcome that they desire and they need? And can I do it in a way that preserves motion? Can I do it in a way that's minimally invasive? But, my basic test is, if this patient comes back to our waiting room, is sitting in my exam room, are they going to be happy? Are they going to be happy? And, and I operate on, a lot of people in the community where I live downtown in New York. I operate on parents from my kids' school. These patients need to be happy when they're done, because that's the kind of practice we have.
I'm curious too, it's such a great point when you talk about the care that you're providing, right? I think one thing that we resonate with you very strongly on is that aspect, right? Like, as a surgeon, your job is to do surgery, right? Which is what you get paid to do. So it's tough to push the other side of the spectrum.
But you
of
have to have the balance of
not operating or doing conservative care, right? And so when you're talking through that stepwise process, I think we love the idea of kind of like less is more, right? You can always do more down the road, but you also don't want to do an operation that's going to give somebody 3 months of relief, right?
Exactly, right? Like, you never so you never want to do the wrong thing. And again, I use the word durable, right? Within reason, right? And sometimes I have that conversation with my patients. Like, listen, we have options here. We could do something small, but there's a likelihood you're going to be back. And I don't have a crystal ball, but there's a certain likelihood you're going to be back. Or we can sort of treat this problem more definitively the first time. And here are the pros and here are the cons. And this is how, I think it's going to go. And I try to make these decisions together with the patient. And I find that's the best way.
Yeah. I love that, the together, because I think as a patient, that just makes you feel better too. Because this is a scary thing. The idea of just like, oh, I might need spine surgery. You have a surgeon who's like, you feel like is on your team. That makes such a difference. And just your mindset going into surgery as well.
Listen, again, I'm fortunate to practice in this environment where I have a lot of time to take with my patients and to go through all the scans, to go through the MRIs, on the big screen, and to draw the arrows and pull out the models and explain what's going on, and, and then come to a decision together. Now, listen, I have patients that come in sometimes looking for something, and I do not think that is the right thing for them. And I will tell them as much, and I will encourage them to get a different opinion. So, one of my mentors when I was at Penn, he said, never get talked into surgery. Right.
I think that's going to go on the wall. That's such a good one-liner. It's so when we talk about this, there's two concepts that you brought up that I really love. So you talk about durability, and then you talked about, when we were talking about a total joint replacement, about expanding indications. I think it's a really interesting thing that we're starting to see in spine. When you're looking at replacing your knee or replacing your hip, you generally don't wait until the very last minute and you're in excruciating pain or pushing off surgery as long as you can, right? We talk to a lot of patients. We talk to even surgeons who say, you should push off spine surgery. It's like the one specialty where it's like you should push it off as long as you possibly can and wait.
So I don't always agree with that. And
what's your
right?
perspective?
That's exactly what I wanted to get to.
In general, I would say, spine surgery gets a bad rap.
Agreed.
All right. Like, if you were to sit in my waiting room, if you were to like really talk to my patients, or even just like go online and look at reviews, like my patients are by and large super happy, right? They're super happy that they did things. And you know, I will tell patients routinely when they have a, more of a back pain problem. So listen, they're different kinds of patients. They're patients that come in with a neurologic problem where they have pain, weakness, numbness. There's neurologic dysfunction. They may have spinal cord compression with clumsiness, or they're losing the ability to use their hands. Those things can't wait. It's very clear that waiting on those things too long can be harmful to the patient. And for those patients, I make a strong recommendation, or I may even bang the table, that they need to get something done. It's the patients that don't have those sort of deficits and serious problems, but who do have back pain or neck pain, where they're trying to decide what to do. And so I'll say, a classic kind of patient that I see is someone who has an isolated like L5-S1 problem. They may have even had a herniated disc. They might have even had an old MRI. It was treated non-operatively. Maybe it was treated operatively. Maybe they had a discectomy 10 years ago. Maybe they had an injection. Maybe they just did PT. Maybe they just white knuckled it and toughed it out. But they have a history of this herniated disc, may or may not have been treated. And then what happened to that disc over the last 5-10 years? That disc continued to degenerate. And now they're bone on bone, or they have a very degenerated disc at L5-S1. And those patients will come in and talk to me about their back pain. And I'll spend a long time talking to them. And what I'll tell them is that, listen, if this is something that you're just dealing with, and you can take some over-the-counter anti-inflammatories like an Advil or an Aleve, and you can do your stretches and you can manage, then by all means continue to manage it. And if it flares up once or twice a year, manage that as well, right? This is not the kind of surgery that I tell you have to have. It's the kind of surgery you tell me you have to have, right? But when your back pain is at a place where you're having back pain 4 or 5, 6 out of 10 every day, when you wake up every day and you're wondering, is this going to be a good day? Is this going to be a bad day? When it's hard to focus at work, when when you have an obligation on your calendar and you're worried about it, how am I going to do with that plane flight? How am I going to do with that car ride? Oh, I was invited to this party. Am I going to have to stand? It's like, is there going to be a place for me to sit down? When it's affecting your day to day, you can't focus at work. Like, I can make you better. Those patients do well. Now, maybe because I'm as conservative as I am, when those patients finally do decide to proceed with surgery, it's a highly selected patient population. But those patients do great, is the truth of the matter. So when someone says, you should push it off as long as you can, I have patients who are losing years of their life, or quality years of their life, because they're pushing it off, is the truth of the matter. Then I have patients who say, well, but if I have this, I might have another problem later on. I have this conversation all the time. And I try to explain this, listen, doesn't make sense to not treat the problem that you 100% have now and is a real problem, because you might have another problem in the future. It's like going to the dentist and saying, well, I don't want a filling because I might need a filling on the other side. And, to a certain extent, the motion preservation technology, I think, is very appealing in that scenario, right? Because one of the things that I think legitimately patients are concerned about or have read about is adjacent segment disease. Now, it's still unclear how much that adjacent segment disease has to do with the added stress on the adjacent disc from a fusion below. We do know that if we leave the fusion in a bad alignment, if you leave the back flat without its proper lordosis or its proper alignment from the side, that can predispose degeneration. Certainly, it makes sense that the stiffness and fewer discs doing the same job as a normal spine that makes sense in terms of predisposing breakdown of the adjacent discs. However, those discs also have the same bad genetics that required surgery at the discs below oftentimes, right? And we do see patients who have fusions for other problems, whether that's a fracture, traumatic fracture, or a stress fracture that may not have the same rate of adjacent segment degeneration. So I think in some ways the jury is still out on that. That having been said, it's very appealing to preserve motion in efforts to stave off adjacent segment degeneration and add-on level surgeries, as we call them.
You talk about some of the research that you did, especially, back early with Flexicore and some of the wear testing, and now we have some biomechanical testing to look at these things, right? We can look at force loading of adjacent segments that are either fusion-based or motion-based. And, you can see them go up by 2 times or 2.5 times or 3 times versus having even hybrid constructs, right? We're seeing more hybrid constructs to kind of reduce the load of some of those. Now, to your point, we can't stop genetics, right? We can't stop genetics, but that doesn't mean we can't provide some protective effect, but we're going to wait to see data. But you nailed the point that we love the most. And I think that's what someone saw their dad or their grandfather or their friend go through in 2000. Spine surgery is so much different now, right? And I think we're kind of can get stuck in that old way.
It's wild.
Yeah.
It's wild. It used to be routine in the lumbar spine that I was going in and making an incision like this, that we were putting in 1 or 2 drains.
Wow.
Where the blood loss was half a liter or at least a few hundred cc's. And for that same procedure now, I make 2 1-inch incisions, or for a multi-level procedure, slightly larger. It's almost no blood loss. The infection risk is, it's not 0, but it's low, right? Like it used to be, you'd be taking patients back for infections, not uncommonly. The infection rate has plummeted. The length of stay in the hospital used to be that patients stayed 3 or 4 nights for a 1 or 2 level lumbar fusion. Now, potentially outpatient, going home the next day, maybe 2 days. I now put in almost all of my lumbar pedicle screws robotically assisted. When I first started out, it was all open, freehand, eyeballing it. Then we moved to minimally invasive techniques that were radiographically driven, where I was wearing lead and, working around an X-ray device in the surgery. And now you talk about enabling technologies. It's navigation, advanced imaging, robotics, virtual reality, or, assisted imaging, augmented reality. There are navigated drills and burrs coming out where you can program in your boundaries, or you could sort of program in your color by numbers, and the drill will turn off or slow down or beep if you get towards the coloring outside the line, so to speak. So I agree with you that we're now at a new era of investment and innovation in spine surgery, where you do feel some of that excitement of the sort of middle 2000s now. I would say.
Well, we're having a lot of fun with it. That's it's fun to come and sit down with surgeons like you and, engineers. We try to talk to a bunch of different people because it's like, this is a really exciting time in spine, and what these enabling technologies have opened up for other potential devices or surgery types, right? Where motion is now having a moment again, where we're saying, in early 2000s, it's just, there were things that we just weren't ready for yet because technology wasn't there to make it accessible to us. Where now we have things like MODIS that, we're eager to see what the data will say at the end of the trial, but that's been worked on for 20 years. We weren't quite ready for it 20 years ago, where now there are technologies where surgeons like you're like, I think I can do this MIS. I'm excited to see what that looks like, where that's a very different surgery 20 years ago.
It's a very different surgery. When you start marrying some of these things, it gets very exciting, right? So when you start marrying a posterior only motion preservation device with a minimally invasive technique where we have a lot of experience, potentially with some of these new technologies like navigation. So again, you're not eyeballing the placement for one of these devices or just relying on two-dimensional x-ray, but you have a three-dimensional intraoperative CAT scan or CT scan with navigation where you can really pre-plan and dial in the location for a device like Modus so that your center of rotation is tailored to the patient's anatomy. It's exciting. It's very exciting.
I'd love to hear, kind of in that same vein, the idea of what that does for accessibility. Because, we hear a lot of like, when you do motion preservation, precision is oftentimes a lot more important than in fusion, where fusion, you can be, you still want to be precise, but there's a little bit more give and take there, where if you're doing motion preservation, like if you're doing an anterior lumbar disc, precision is really important to see success. So with these enabling technologies, do you think that makes it more accessible to more surgeons' hands?
Absolutely. I mean, absolutely. All of these things, navigation, robotics I don't think I've had a bad lumbar screw. I don't want to dare the gods, but I haven't had a bad lumbar screw since in 5 or 6 years since I started using the robot. Now, again, I count myself lucky that I trained in an era as an open spine surgeon, right? So, I have all the feels of doing this with my eyeballs and the haptic feedback of a probe, and I know what a good screw or a good tap feels like. And so, I've heard people say that, robotics doesn't make a bad surgeon a good surgeon, but it makes a good surgeon a great surgeon.
It's a good distinction.
Right? So all these things help. And I do think to a certain extent, they're more effective guardrails, or like, my kids go bowling and now they have the bumpers that come up,
so do I.
So they can't go into the gutter, so the ball can't go into the gutter. So I do think that some of these things, whether it's, active hunting protocols for triggered EMG so that that you're near nerves, whether it's navigation, whether it's better imaging, whether it's augmented reality, all these things help. But ultimately, it's the surgeon that makes the outcome.
Yeah.
It's fascinating too. We talk about all these technologies and I think it's amazing, but when I go back to what you said previously, and I want to touch on it because I think it's important, we talk about motion preservation. It's a big umbrella, right? So we talk about lumbar discs and we've talked about, lumbar total joint replacement now and cervical discs. Hopefully all will be, cervical discs and lumbar discs are available. Hopefully lumbar total joint replacement will be available soon too. But motion preservation also includes non-implanted procedures. And I think that's very important. Can you distinguish and talk about that a little bit too, of like, the whole goal is motion preservation, right? It doesn't always have to be an implant, right? And sometimes that's a less is more.
Sure. Listen, doing a lumbar decompression, a minimally invasive lumbar decompression through a tiny tube or endoscopically, or using the microscope, we're doing the same procedure that we once did with a much bigger incision, with much more removal of bone, removal of ligaments, removal of other supporting structures. So by maintaining more of the spine's healthy connective tissue and healthy anatomy, we're maintaining motion, right? And certainly, there are things that I do minimally invasively where previously it would have necessitated doing a fusion, right? Because if in order to get to things or to get to things effectively, if you remove too much bone, if you remove too much of the joint, then that may necessitate a fusion. So it's not uncommon that I see patients that have gotten an opinion elsewhere that come to see me for something where the surgeon has said, well, you need this nerve unpinched and we're going to have to do a fusion. And I say, gee, I think that I can do this in about 20 or 30 minutes through a dime size incision and send you home the same day. So that's motion preservation, right? Cervical laminoplasty. That's not a small incision, But, cervical laminoplasty, which is done through the back of the neck, involves elevating the roof of the spine and then often putting in either wedges of bone or putting in tiny plates and screws to keep it open in order to decompress a pinched spinal cord in the neck. That, in the right patient, is a superior procedure to, what's called a laminectomy and fusion, where instead of hinging open the roof of the spine, you remove the entire roof of the spine, and then that really necessitates putting in screws and rods.
And why is that? It's for stability, correct?
Because you remove too much of the stabilizing tissue, the so-called posterior tension band of the cervical spine, that, we now know it's imprudent to perform a laminectomy without a fusion, because the patient is at high risk for falling into what we call post-laminectomy kyphosis, which is a fancy way of saying that because you don't have that band in the back of the spine that's keeping your neck up, that your head can fall down. That having been said, yesterday I performed a laminectomy and fusion in a patient who needed it, right? Again, the most important thing is patient selection, choosing the right patient, trying to keep your patients out of surgery, but then when they do need surgery, tailoring the procedure to that specific patient and the specific problem that they have. And even though I have an eye towards these newer technologies and these smaller surgeries, that's not always the answer.
Well, I think it's about like your having as much in your toolbox as possible, because we're not all created equal, and we're as unique as our thumbprints, right? So what works for one person might not work for another. And so it's great, like if your sister was able to get a disc replacement, but maybe that's just not possible for you, and you do need a fusion, and that is your best option. But being able to have your full toolbox to be able to say, I can uniquely decide what works for you, I think that's what's most important.
And I think that's in some ways the hardest part of our job, and the most important part of our job is that tailoring the solution to the patient.
Yeah. We talked about that with Dr. Nunley at NASS, where he was like, that is the biggest thing, is the decisions that I have to make. Like those are the big moments where it's like, I have to decide what is the right option for you. And those are big things of like looking at you specifically. What do I really think is right for you?
And Pierce Nunley is a super guy, and I've known him for a long time. And if any of your listeners are in Louisiana or down that neck of the woods, he's probably your guy. I couldn't agree more.
Yeah.
So as a patient, it's great. I think it's a great topic for a surgeon that has a multitude of options. But I think there's another side to that as well, right? And you as a surgeon, just because you have 100 tools doesn't mean that if you pull one out once a year, that you're going to be really, really well versed in that. So like as a patient that's coming in and you're looking for motion preserving options, or you're looking for someone that does that, how do you find those people, right? Like you offer 5, 6 different cervical discs. You offer Mobi-C and Prestige and ProDisc, M6, right? Simplify. You have tons of different stuff. You know it well. You've done tons of them. But to your point, someone that maybe does one of these every 2 or 3 years, we do know that they need to be precise. We know that they need to be in the right person. How do they go about finding the right person?
Finding doctors is hard.
Yeah.
Finding doctors is hard. I would say, like, I used to joke that my second job was eating out in Manhattan. But now I kind of joke that like my second job is as a medical concierge, because every day I get a text from someone that I know, do you have and it may be from another doctor, do you have a recommendation for this problem or this kind of doctor in the city? So finding doctors is hard. I think, first of all, personal recommendations, that's the best, right? Personal recommendations are the best, recommendations from other physicians. But listen, there's a wealth of information that you can find online. You can really look at the sort of training that somebody did, where they trained, where they went to school, what kind of surgical training they had, where their research interests may lie, what kind of institution they're at. Listen, at NYU, we're running, many spine rooms every day. We have an interdisciplinary spinal conference every week with ortho surgeons and neurosurgeons and all the fellows and all the residents. I think it is important to, look towards a center of excellence or a surgeon of excellence.
You've been doing this about 20 years. You're in the heart of New York City. You've got patients that, travel. Like you said, you've got kind of concierge type people. Yeah. You've got A-listers. You've got those folks that are coming in and doing that. How has that changed over time? Because Courtney brought it up too, is that just access to information has been different, right? And so now I think we're seeing more and more patients who get access to information, find either the surgeon or the type of surgery that they'd like to find, and then they're willing to travel for that as well. I'm sure you guys see plenty of that here.
I mean, they certainly are, right? So, and I think that's great, and I'm happy to provide that service, is the truth of the matter. At the same time, I would caution against, just giving the buyer what they want because they're willing to come see you, right?
Absolutely.
Like you still, again, I can't emphasize enough the importance of tailoring the procedure and the technology to the patient and the specific problem, that they're having.
So you've been doing this a long time. You've seen a lot. You've been through a lot of the iterations of motion preservation. And now we're seeing these enabling technologies, right? We're seeing MIS, we're seeing nav, we're seeing robotics. What has you excited? You have a long career left ahead of you, right? And a very, you're going to be doing a lot of different things. You're going to be continuing to push the boundary on advancing care. What do you get really excited about as you see these new technologies come up, as you see these new technologies start to merge together? What is it that has you excited?
It's an exciting time. I know I ran into the two of you at North American Spine Society in Chicago, but I was able to go and demo or get trained on like 4 different robots that haven't quite made it to prime time yet, and they bring you back into the booth or into the trailer with to close the door and sign your so it's an exciting time to see this stuff. I do think that the robotics and the navigation and the enabling technologies are meaningful. I remember going and seeing the first real like FDA approved spine robot, which was the first generation or the first US approved generation of the Mazur robot that was consequently acquired by Medtronic, but that was the sort of the soda can that you attached an arm to kind of thing. And I remember I came back to NYU. I said to my colleagues, like this is going to be the future of things, right? There's nowhere else where you're free-handing a drill and a screw. Like when your computer or your iPhone or your car is made, you don't have guys in the assembly line like, yeah, I think I'll put a screw here, kind of thing. Yeah. And it's taken a while for the technology to catch up. And that's definitely where we're heading. And I think that level of precision will allow us to further other technologies, whether that's Modus or other types of implants that require much more refined and detailed preparation or implantation.
What I think is really exciting too is we talk about the success metrics of surgery, right? And some of that is how patients are feeling and, they're kind of subjective. Here's my pain levels. Here are these other aspects. But I think we're starting to see different, even functional outcome metrics, right? Because for a long time we would treat, the x-ray looks really, really good, or we were able to restore lordosis, right? And that's great. And that's the first step. But the next step is like, how many steps can they take after surgery? And is that a day after surgery or a week? And when are they getting to return to work? Do you think we're going to see some of that change as well as looking at functional outcome metrics for success of surgery versus kind of what we looked at, historically?
Well, I think it makes sense that it would follow that as the technology gets better and the procedures get better, then we're going to need more granular and detailed outcomes instruments in order to assess effectiveness and superiority between techniques and technologies. So I agree. I think if you look at sports and the elbow and things like that, their outcomes instruments are very sensitive to sport and motion.
I just think it's exciting in spine because I think we've looked back retrospectively, and I think a lot of patients have that in their head of, what my dad had or what my sister had or what my friend had 10 or 15 years ago. It's just so different now. And it's changing so rapidly too. So we need guys that are willing to, like you have surgical demos online that people can look at and watch and see what it's like. We didn't have access to some of those things 20 years ago, right? That just didn't exist. And I think that's changing the landscape too of what's available, what patients have at their fingertips, but then what surgeons have at their fingertips. Then how do we train everybody, right? Because then there's this other aspect of you can have great technology, but then you have to train everybody up on it, right?
And it goes further, right? So there's this quandary that you have. Like I trained as an open spine surgeon. I trained putting freehand screws in, X-ray driven screws. Our fellows now are putting most of their screws in with the robot.
So they haven't experienced that same.
And we try to give them, and we try to give them that experience on some of the bigger cases, on the deformity cases and otherwise. But, people make the analogy to like laparoscopic surgery and general surgery when it first came out that the surgeons now, there's no surgeon my age or who's younger than I who has done like open gallbladder resection. I mean, that is the standard of care is laparoscopic, cholecystectomy. And so, it's a whole different skill set to teach and to learn.
How do you go about doing that? Because, you've worked with so many new technologies. You're kind of on the cutting edge when we talk about MIS and robotics and navigation. But it's really a balance, right? Because you're not going to use something unless it's going to benefit the patient, right? Like you're balancing this innovation and patient safety. How do you go about innovating and choosing the devices that you're going to work with and then implementing them into your practice? Like, how do you go about making that decision?
Listen, that's hard, right? And someone once said to me, Jonathan, you want to be on the leading edge, not the bleeding edge, right? So, for instance, I was the first surgeon in the US along with one of my colleagues at NYU to put in intrinsic therapeutics barricade device, which is an annular closure device, which in its own way, I think is a motion preserving technology because you're preserving the disc and the disc moves versus being accelerating the path to fusion or another procedure. But, for that technology, I went to Europe, I went to Belgium and Austria, and I was in the operating room and, watched surgeons implant it and, went through their original data set with the research team at NYU and looked at their outcomes, looked at the images and things of that nature. In addition to doing cadaveric work and practicing in the lab before bringing that to patients in the US.
It's like a slow and steady, right? Because you have to wait for some of the data, but and I think we saw that in motion preservation too. It's like we have 7-year and 10-year clinical outcomes on a lot of discs, right? And there's kind of, you get still some of this conversation of, it's untested. We have to wait and see. It's like, we have 10 years of results data, right? It's a little bit different than untested and unproven, right? Like that's a totally.
Well, listen, I mean, the folks at 3Spine, Dr. Hodges, are, I think, very, very bright and very thoughtful and been measured and prudent in the way that they've, brought this technology forward for us.
So we're sitting here in the practice that you've established and has been going for a long, long time. I believe you guys have been here for 8 years now here at OrthoManhattan at the location that we're sitting at. But I believe you recently just opened up a new practice as well, OrthoEnglewood. Do you want to talk a little bit about that and setting that up and what that's been like?
That's been something in the making for a number of years now, with some of my partners and also some of the other highly respected surgeons at NYU. So, my partner, Roy Davidovich, has been an innovator in outpatient anterior hip replacement. And if you were to Google him, you'd see he's done a number of actors and actresses and models and people you would know kind of thing. Our goal was to develop a purpose-built outpatient center for orthopedic and neurosurgical cases. So we are just now opening after a lot of development and a lot of hard work in Englewood, New Jersey, what's called NYC Joint and Spine Center in Englewood. And so this facility has large operating rooms that will allow for total joint replacement, potentially spinal fusion procedures, disc replacement procedures, motion preservation procedures, along with the full complement of technology, enabling technologies, imaging technologies, robotics, to fulfill that dream of bringing these procedures, which more and more are being done on outpatient procedure, to fruition. And the idea here is that we could have control as surgeons of the entire sort of episode of care.
Mm.
Now, listen, I will always have the hospital and need the hospital for certain patients and certain procedures. And not every procedure and not every patient is suitable for having their surgery done in an ambulatory surgery center, however advanced or technologically adept it may be. But the idea here is to give the patient the end-to-end care experience of a concierge type practice where the center is set up for what they need.
Mm-hmm.
When you walk into the hospital isn't just set up for outpatient surgery. It's set up for emergencies. It's set up for really sick patients. Half the people that are going in there are visitors who aren't having anything done. They're stopping you from bringing flowers upstairs, things like that. And even the surgical check-in process for the main operating room is in some ways more involved and laborious than necessary for a smaller, more discreet orthopedic or spinal procedure. So in developing a center that's ours with our staff, our protocols, we're able to control the entire experience, not just for the surgeon, but for the patient. When we looked initially to do this in Manhattan, frankly, unfortunately, it's just in some ways prohibitive to do it in Manhattan, partially from a cost standpoint, partially from a regulatory standpoint, partially from a political standpoint. So we looked, where would the closest place be that we could reasonably do this? And so, this center is located right over the George Washington Bridge in New Jersey, and it's accessible, not just to our Manhattan patients, but to our New Jersey patients coming from Westchester and from the north. And frankly, and I live in Manhattan, I live in downtown Manhattan, it hasn't gotten easier to come into Manhattan. It hasn't gotten cheaper necessarily to come into Manhattan. So, there is a population of patients who are happy to not have to come over a bridge or a tunnel to come see us.
Or for those patients coming from out of state or out of the country, that can be a little bit of an easier place to manage than trying to make your way through New York.
So we are putting together packages where people could come into Newark Airport and stay at a hotel and have that all arranged for them and work with them to streamline the whole process.
We get really excited talking to surgeons like yourself. You're a surgeon and you've built this incredible career as a surgeon, but you're also an entrepreneur and an innovator, right? Like that's what building this practice is. You have this practice and you guys are being able to build out, and it's all with the goal in mind of improving patient care, right? And improving the patient experience and getting patients out and ambulatory sooner, right? I mean, that's the goal of expanding this, is giving people better access, more access to better technologies, the most up-to-date technology. That's what it's all about, right?
Well, that's why we do what we do, right? Everything we do ultimately is for the patients. And if the patients are happy, the patients do well, then we have a very gratifying job and profession. And, listen, there are a lot of easier things to do with your life than to be a spine surgeon.
Didn't go into it for the easy route.
And the reason we all do this is because it's just tremendously gratifying to have a, successful procedure or a successful treatment of a patient. And so the more we can control that whole process, both from the medical side and also from the experiential side, that allows us just to deliver the best possible experience and situation.
Well, it's incredible. We've been very fortunate to get to know you. And like you said, we ran into you at NASS, and we've known you previous to that as well, because, the NYU connection, and we know Dr. Jeff Goldstein very, very well. And it was funny, when we talked to him as well, way back when, I believe you were one of his fellows, 17, 18 years ago.
I was.
Which is so funny. But, I think we get this true innovation and improvement of patient care when you have the right people around, right? You have innovators around, you have people that really care about these things and think about them day in and day out, right? Obviously we know Dr. Hodges very, very well, but you get Dr. Hodges and Craig Humphreys, and, we know Dr. Goldstein and Nunley, and you start to bring all these people together like yourself. That's when you improve care, right? Is when you have all these people that essentially have this burning passion to really improve where we're at right now. And I think that's exciting to be part of. I mean, we're fortunate to be able to sit down and have these conversations, right?
Well, happy to be here.
This is an incredible center. We're in the heart of New York City. For patients that are looking for you, where do they find your stuff? Obviously, you post some of your work on Instagram, but where can patients come and find you if they want to, get a second opinion or come and see you? Where do they come find you?
Sure. Well, we certainly have a web presence with OrthoManhattan website, now the OrthoEnglewood website. I have my own website at stiebermd.com. We do have some social media presence as well on Instagram and YouTube. Just I think searching spine surgery in Midtown Manhattan, or
they're going to find
they're going to find us.
Well, your list of accolades certainly precede you. You're a phenomenal guy. A spine surgeon, the things that you've done for the community, and you've been listed on everything. You have about 3,000 followers on Instagram. You have a YouTube channel with over 1 million views on it. And then you're a dad to 2 girls. And that is a full-time job right there.
That's the best and hardest job.
Yeah.
Well, we appreciate all the time you've taken. We're so grateful to be able to sit down with you, and we know there's a lot more to come. So we're excited to continue these conversations down the road, but we appreciate you giving us your time today.
Super. Thanks again. Great talking to you.
Thank
you,
so
Dr.
much.
Stieber.